Welcome to this presentation on hypoglycemia or low glucose. I want to first acknowledge with gratitude that this presentation was created on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations, and to thank the Indigenous peoples for their stewardship of these beautiful lands. We're going to talk about signs and symptoms of hypoglycemia, the treatment of hypoglycemia, and some special considerations to think about. The Diabetes Canada Clinical Practice Guidelines outline the blood glucose targets for most people to be between 4 and 7 in a fasting state, before any other meal of the day between 4 and 7, 2 hours after a meal between 5 and 10, and an A1C of less than 7% or less than 6.5% if that can be achieved safely without hypoglycemia. Any adult where safety is concerned, the targets are flexed to individualize those targets, and the A1C could be allowed to be as high as 8.5%. And in end-of-life situations, we don't test the glucose that frequently, and we aim for quality of life and safety. So hypoglycemia is defined as a glucose less than 4 in people with diabetes. People without diabetes can routinely have glucoses in the 3s overnight, and that is not an urgent issue because they have the whole mechanism of being able to release glycogen on demand. But in someone who's taking a sulfonylurea like glyburide or glycoside MR or insulin, we want to be concerned when the sugars are less than 4. If they're routinely hyperglycemic, someone with a higher sugar could experience signs and symptoms of hypoglycemia with a higher glucose result. For example, if they're routinely running in the 20s and they drop down to 10 suddenly, they may experience some signs and symptoms of hypoglycemia because of that sudden drop in the glucose levels. They may or may not have any signs and symptoms, and that's called hypoglycemia unawareness, which is of great concern because they don't have any triggers or warnings for anyone else around them. I also want to point out that you would still treat someone who has a drop in that glucose from a higher level, even if the glucose level is greater than 4. If they've had a sudden drop from 20 down to 10, then you want to give them something to support that drop and not have them drop even further, because those autonomic symptoms are very disturbing and really quite uncomfortable. Also want to remind that hypoglycemia is a life-threatening event and it does require treatment. If left long enough without glucose to feed the brain, heart, and kidneys, death can occur, and long-term effects include cognitive and memory impairment and heart problems. So here are some of the signs and symptoms of hypoglycemia, knowing that each individual may experience different symptoms, a combination of, or something very different than on this list. But typically it's a dizzy, shaky, sweaty, feeling hungry or hangry, lethargic, slurred speech, headache, uncoordinated movements. Some can have numb lips or tongue, confusion, irritability, and finally coma. I had one lady that I met who said that she felt numbness and tingling under her breasts prior to a hypoglycemic event. It's not on the list, but it certainly is on her list, and we would take that seriously. So if someone is having hypoglycemia, if they're able to swallow, we want to give them 15 grams of carbohydrate if it is glucose greater than 2.9. So if it's between 2.9 and 4, then we would give 15 grams of carbohydrate in the form of regular juice or pop, and that would be 175 mils. Glucose tablets, the Dex4 tablets, you need to give 4 of those, and they're quite large, so they need to chew 4 of these larger tablets, so they're a little more disruptive to someone to try to get those down. You can have sugar packets, and they can pour the sugar packets right into their mouth. 3 of those sugar packs will equal 3 teaspoons, which equals 15 grams of sugar. And 2 times the 20 ml honey packets as well. That will also boost them up. For every 15 grams that you give, it will boost the glucose in 15 minutes by about 2 millimoles. If they are less than 2.9, then you want to give 20 grams of carbohydrate. If they're not able to swallow, then you need to give them something else. You don't want to try and put fluid down their throat. So Baqsimi or nasal glucagon is the only product in Canada available. It is covered under BC Pharmacare, and that is a nasal glucagon which is sprayed directly into the nostril. Requires no coordination from the patient or cooperation. You just press that tab on the bottom to fully dispense the drug into the nasal cavity, and that will absorb. They also could take glucagon subcutaneously or intramuscularly, and D50W, not D5W, D50W, a half an amp, which is about 25 mils, or a full amp, depending on how low they are. And do remember, glucagon can cause nausea and vomiting as well, so that recovery period might involve them feeling nauseous or requiring to vomit. It's also important to note that if a patient's on a severely reduced carbohydrate diet, or like a keto diet or Atkins diet, or they're cachectic and they have not taken a lot of carbohydrates, there's going to be no glycogen stores in the liver to draw from. And this means that you cannot give glucagon because its action is to stimulate the release of glycogen from the liver. So this is where D50W is a must and has to be given by either paramedics or in the hospital setting. I've included an example from Providence Healthcare on an algorithm for treatment of hypoglycemia, and it essentially goes through what we've just said. If they can take something orally, they will. If they are not able to swallow, we will use Baqsimi or nasal glucagon as well, or D50W for this. And then it walks through rechecking the sugar in 15 minutes after the treatment. If the glucose is still less than 4, then you can give an additional treatment and retest 15 minutes later. However, it's really rare for someone to require 2 treatments because, as I mentioned, the glucose should go up by about 2 millimoles, and unless they are 1, which really on a blood glucose meter or even a continuous glucose meter, the readings in the less than 3 range are not as accurate. So it's very rare for somebody to be that low. So here's another example of, and includes that if if a woman is pregnant, that those low glucose levels are actually altered because they have have lower glucose targets. So if the glucose is less than 3.3 in pregnancy, then we would follow this algorithm as well. So how to prevent hypoglycemia? Sure, we can detect it, we can treat it, but we want to prevent it from happening again because this is really not healthy for the body to experience. So we want to look at their insulin and their anti-hyperglycemic regimen. So is the glyburide or glycoside MR, the pills that they're taking to stimulate the pancreas to put out more insulin, is it too much of a dose now based on what they eat or their current condition? Is it causing low blood sugars in between meals, which it can do? If they're on insulin, did they give too much of their insulin or not eat enough food? Then we can examine what led to this in order to provide some education for the person to not have this happen again. We want to advise the person to bring a source of glucose with them. So that would be in the form of either candies or gummies, and always the Baqsimi, especially if on insulin, or a sulfonylurea. We want to make sure that they have something to treat immediately. And as someone who prefers chocolate, certainly would love to advise that, but the high fat content in chocolate delays the absorption of the carbohydrate, making it even a longer delay in treatment. Also wearing something to advise others of the risk, like a medic alert jewelry. I have someone I know has got a forearm tattoo so that it's on their wrist area there, and that someone who found them possibly passed out could identify that they could have hypoglycemia. Eating regular meals is really important as well, not skipping the meal. And this is in particular importance in people on a mixed insulin regimen, because you can't pull that insulin out once you've given a mixed insulin of either Humalog Mix 25 or a 30/70. You've got insulin working for the next meal as well as through to supper when given at breakfast. Also, I've got a whole module on driving and hypoglycemia, and they should be checking their sugar, whether that's through a CGM or through a blood glucose test before they drive, and at least every 4 hours as they are driving. And as I mentioned throughout this presentation, the continuous glucose monitors are so helpful in being able to monitor the glucose levels, predict that there is a low impending. When the arrow, the trend arrow that says the direction the sugars are going is dropping quickly, it sends a message to the meter which alerts the person wearing it that there's a possibility that your glucose is going to drop in the next 20 minutes below the 4 millimole threshold, and that you should do something to prevent that. Alarms can be set at whatever level they would like, although there is a hard alarm on all CGMs at 3.1, so if the glucose level reaches 3.1 or less, then there is no turning that alarm off, because that is a critical low. But they could set it at 4.5 with a trend arrow going down, saying that in the next 20 minutes you're going to go less than 4. Definitely, we work with the person wearing the device to make sure they don't have alarm fatigue, and to make sure that it's acceptable for them, because an alarm that keeps going off can really upset a person's life, and they might just keep turning it off and ignoring it. And glucose results and trends can be shared with family members when they do wear these devices. So it's interesting, a parent of a child at school can see if the glucose levels are dropping. And we've had instances where they've called the school and said, look, my daughter's glucose level is going to drop quickly soon. Can you get some sugar into them? And then that can be the same with your partner, with an older adult as well. You can actually go and check on them and make sure that everything's okay. So the key messages from this presentation is that hypoglycemia is a life-threatening event and it requires intervention. Symptoms can vary between people. If they were able to swallow, they should take oral glucose. And if they're unable to swallow, nasal glucagon or injectable glucagon, and again D50W in the extreme cases. But that has to be done by a paramedic or in the hospital. If a person's on a severely reduced carbohydrate diet, they may not have any glycogen stores, and D50W must be given. And then reviewing the signs and symptoms and treatment of hypoglycemia and some of those contributing causes can help them prevent further episodes, as well as CGMs being very helpful to predict and possibly avoid the hypoglycemic event, as well as sharing with family and caregiver for added safety. Thank you.